Good afternoon and welcome to today's webinar, Pressure Points for Dementia Caregiving, Behavior, Driving, and Firearms. I'm Leslie Samay, Director of Professional Development at Great Valley Publishing Company, publishers of Social Work Today and today's Geriatric Medicine magazines, and I'm your host for today's webinar. Before we get started, I have 3 points of housekeeping. In order to claim your continuing education credit, you'll have to remain with us through the entire presentation. Second, our accreditation statements. In support of improving patient care, this activity has been planned and implemented by Great Valley Publishing Company and Right at Home. Great Valley Publishing Company is jointly accredited by the Accreditation Council for Continuing Medical Education, the Accreditation Council for Pharmacy Education, and the American Nurses Credentialing Center to provide continuing education for the healthcare team. As a jointly accredited organization, Great Valley Publishing Company is approved to offer social work continuing education by the Association of Social Work Boards Approved Continuing Education Program. Organizations, not individual courses, are approved under this program. Regulatory boards are the final authority on courses accepted for continuing education credit. Social workers completing this course will receive 1 general continuing education credit. This activity was planned by and for the healthcare team, and learners will receive 1 IPCE credit for learning and change. This activity is also approved for 1 continuing education contact hour by the National Academy of Certified Care Managers. It is the responsibility of the participant to follow these steps to obtain continuing education credits. And this activity is approved for 1 American Nurses Credentialing Center contact hour. Finally, the faculty and planners for this educational activity have no relevant relationships with ineligible companies to disclose. An ineligible company includes any entity whose primary business is producing, marketing, selling, reselling, or distributing healthcare products used by or on patients. And now I'm pleased to introduce today's presenter, Dr. Barbara Messinger-Rapport. She assesses older adults referred by senior professionals who express safety concerns regarding financial exploitation, driving, firearms, and other triggers of difficult behavior. Dr. Barbara is also a medical director for Oak Street Health, a senior healthcare company. Prior to that position, she was the medical director of Vinnie Palliative and Hospice Care of Menora Park Senior Living and director of geriatric medicine at Cleveland Clinic. When not working, Dr. Barbara enjoys biking with her bicycle and her motorcycle, cross-country skiing, and jogging. And now I'm pleased to welcome Dr. Barbara, and let's get started with our webinar.
Leslie, I want to thank you for that lovely introduction. I am honored to be here, and in particular, I'm honored to be presenting to this interdisciplinary team of people who are caring for older adults with dementia. You, my audience, are in their homes, or you're working with caregivers in your offices. I suspect you already know a lot, and perhaps more than I do, about many of the practical issues of dementia caregiving. The topics that I'm going to present are specialized, and I'm hoping that you can use them to add to your toolbox to keep our dementia patients and their informal caregivers safe in the community as they navigate the difficult journey ahead of them.
Excellent. Thank you for that welcome, Dr. Barbara. Let's open with a poll. By a show of hands, when you hear your healthcare role noted, please just raise your hand so your peers can see who is in the audience with you today. So which of the following best describes your role as a healthcare professional? A, primary care physician, NP or PA. B, specialty physician, NP or PA. C, therapist. D, licensed social worker. E, nurse. F, pharmacist. G, case manager. H, care manager. I, caregiver, family or friend, so in an informal capacity. J, home health aide. K, dietitian. Or L, other. And if you picked L, just shout out what your role is. Next on our poll, are you a part of an interprofessional healthcare team? Raise your hand if A, yes, B, no, or C, not yet. Maybe you're wanting to be a part of a healthcare team. Excellent. Thank you for your participation. Okay, Dr. Barbara, I'm going to kick it over to you to take things away.
Thank you. So below are some disclosures that are a little bit tongue-in-cheek. My college rifle club, I was a member. I have a rating from the Air Force when I was active duty, which was a long time ago, as an expert marksman. I own a gun locker, but it is empty. I've had no recent motor vehicle accidents on either the motorcycle or the car. And something that will give you an idea of where I'm going with some of the discussions below or that are to come. I was told that one year I signed more statements of expert evaluations than any other physician in my county. It's an odd thing to be known for, but it does represent the patients that you and I take care of. So let us jump right in. We're going to be exploring both pharmacological and non-pharmacological management of dementia-related behaviors, but as the physician, I am really only going to discuss in detail the pharmacological management. I am hoping that members of the healthcare team and the multidisciplinary approach that are used, that you will be able to pick out parts of this discussion to improve health outcomes for dementia patients. And I'm going to discuss strategies that social workers and care managers can use to navigate the challenges in caring for dementia patients, whether we're discussing disruptive behaviors, driving safety, firearm safety, and some of the psychological symptoms. So the members of the healthcare team, as referring to dementia, as we think of dementia care as requiring, of course, a village, not just populated by the informal care team, but the various healthcare professionals, the social workers, the care and case managers, the caregivers. Mainly, we're saying that is informal caregivers, the nurse RN, the licensed independent provider, so physician, nurse practitioner, or PA on your team or available to your team. A pharmacist, again, either on your team or available to your team. Therapist, dietitian, home health aide, and there may be more, but these are the core team members that are required to care for the older patient with dementia. So things that the physician or APRN or physician assistant would do involve a comprehensive assessment, provide the diagnosis of dementia, and update the stage of dementia as the person moves through it. Medication management, identify comorbidities. Does the patient have a movement disorder, depression, a thyroid disorder, vitamin deficiencies? And fall risk reduction and safety, including referrals to therapy, are very important. Care managers coordinate and advocate for individuals to make sure that the patient is receiving medical, emotional support and daily living support, especially as the stage progresses, and helping caregivers navigate the complexity of dementia care, both initially and as the condition progresses. Pharmacists can assess polypharmacy. And most in the past few years, pharmacists have been becoming very good at identifying medications that could cause symptoms, as well as telling us to add medications. Social workers to assess the person's values and support system and identify caregiver stress, provide caregiver support and education for dementia behavior, driving, and firearms, connect with community resources, including housing support, transportation. The nurses have a role for polypharmacy as well, and a role to advocate for deprescription, and of course, a role to reduce fall risk, but addressing dementia behaviors, including wandering, and risks, including driving and firearms, often fall to the nurses on the team. So, for a 2-minute check-in, is your team able to address all important patient outcomes in dementia? And you might not have the people in your team. And if you don't, are there community resources that you can utilize to improve patient outcomes? And we'll give you 2 minutes to talk among yourselves about this. Let's jump into dementia and behavior. So I'm going to show you this quote cartoon of the brain where we divide up the gray matter and the white matter. It's a little bit simplistic, but the gray matter is the periphery primarily of the brain, as well as some parts of the interior of the brain. The gray matter is mostly neuronal cell bodies, and the gray matter primarily involves memory, but it also controls movement and emotion and processes information. You are not born with your gray cells mature, but they fully develop in your 20s. All of you with teenagers know that. And all of you who have teenagers know about white matter, even if you're not using that word. White matter are the parts of the brain that are primarily interior. They involve axons that are myelinated, meaning that they are created for speed, and they connect brain regions to help with learning, attention, and motor control. And of course, as parents know, this aspect of the brain peaks at middle age. This is a simplistic way of my helping you understand that there are different kinds of dementia in older adults. And depending on where the dementia arises, tends to drive the symptoms you see. So, for example, Alzheimer's disease is a disease early on of short-term memory. So, in fact, early on, it's the gray matter that's involved. Parkinson's disease early on has a little bit of memory, but mainly controlling movement and emotions. Strokes can affect the gray matter. Uh, and depending on how large the stroke is, it could affect the white matter as well. The white matter, these heavily myelinated axons, can become diseased and lose their integrity with vascular conditions. What are vascular conditions? You know them all, you're familiar with them. Hypertension, diabetes, atrial fibrillation, heart failure, obstructive sleep apnea, we do consider that a vascular condition, hyperlipidemia. So if you as a provider or a non-provider are looking at a CAT scan of the brain or at a radiologist reading of a CAT scan of the brain, and you are looking at or reading about white microvascular ischemia or quote white matter changes, you are primarily looking at the vascular changes in the brain for older adults. Younger adults, this could be something different like multiple sclerosis, as well as some other unusual conditions. But the bread and butter of the geriatrician, these are vascular conditions. Severe head trauma will affect both, and it could be both on different sides of the brain. Most dementia that occurs in the community in the oldest adults, say 80 and over, is what we would call mixed. It's Alzheimer's, meaning memory or short-term memory, and white matter disease or vascular, because these are patients who probably have some of vascular conditions. So you will see both white matter changes and the memory that you have. So because dementia is not just short-term memory, but affects other parts of the brain, then behaviors occur in clusters. So apathy is the primary, even though it's got the smallest circle, it bothers the patient the least. And this is the most prevalent condition or behavior in dementia. And, and it's probably the most misunderstood. Apathy can certainly be seen in a person who's depressed. A person who's depressed is sad, tearful, hopeless, low self-esteem, anxiety, guilt-ridden, and they may also be apathetic. But the apathy of dementia doesn't need to have any of those things. This is a person who actually is pretty much, their normal self, except if you ask them why you're not participating in book club or why you're not bowling with the girls, why you're not doing this or that, I'm 82. I just don't have to do that. I'm fine. No, I'm not depressed. And you look at that person, you might be distressed because you are the caregiver and you don't understand why mom isn't doing all those things. But mom has apathy, and that is part of her dementia. It does not usually respond to a pill. Um, Psychomotor agitation is distressing and it could be unsafe. Walking aimlessly, pacing, trailing a caregiver, restless, repetitive actions, dressing, undressing, packing, unpacking, folding towels, unfolding towels, and sleep disturbances. These do not usually respond to medications either. Aggressive resistance, physical aggression, verbal aggression, these can all be dangerous to the patient or the caregiver. And if the patient is in a common area or lives in a residence of some kind with other demented patients, if he or she is aggressive to someone, then that person might just turn around and bop them. And so a person with dementia could be a perpetrator of aggression and could be a victim of aggression as well. Psychosis is very dangerous, hallucinations, delusions, misidentifications. And many of these can respond to medication. Why do older adults have dementia behaviors? We feel that the actual source is a stress that the person is perceiving. Fatigue, especially in crowds or at the end of the day, competing stimuli, the TV is on loudly, there's people in the kitchen talking, the phones are going off, there's beeping. He or she is being asked to multitask, do this, do that, do it all. The person can feel ill, hungry, tired, thirsty, in pain. And a minor change in the caregiver or in the routine could spark dementia behavior. I had a patient who was really very, very pleasant man who lived with his daughter, and his daughter's boyfriend spent the night. She went off to work. He saw the boyfriend, took a knife from the kitchen, and stabbed him in the abdomen. This was not a violent man. He didn't know what to make of a stranger in his house. So, of course, we advocate for non-pharmacological interventions, and group, your group of professionals may have one or two of these that you turn to for educating your patients and families. The repeat, reassure, redirect, the 3 Rs, the ABCs, antecedents, behavior, consequences. In Cleveland, there's an author who passed away recently. Her name is Naomi Feil, and you will see the validation therapy, validate patients' concerns. There are programs, and again in Cleveland, the SAVVE Caregiver Program, no relationship to my organization. The Alzheimer's Disease Association does have programs for educating informal caregivers. Community resources, larger cities with ADRCs. There are specialized occupational therapists there are dementia care specialists, and then there are research centers with brain centers or dementia centers that can enroll people in trials, can counsel caregivers. Your area is going to have its own set of resources. So first, of course, is non-pharmacotherapy, but second and third is pharmacotherapy. And underutilized is deprescription. And this is where our pharmacists are getting clever. They're looking at patients' lists of prescriptions, which can often go on and on and on, and suggesting that some of those behaviors could actually be made worse by the medications they're on. And then, of course, there's people like me who add medications. In all honesty, I try to do both. Dangerous behavior, like the gentleman with the knife, or I had another patient who I met in the intensive care unit, handcuffed to the bed rail and attended by a policeman because he didn't recognize the man who was coming to check the gas meter, and he took his rifle and tried to shoot him. Luckily, he missed. And when the police came, called by this poor meter guy, he developed chest pain and ended up in the hospital. So there are people that you're just not going to wait before you start a medication. So the first thing to look at in deprescription are look at medications that may have caused delirium or an acute confusional state, and for some reason were just continued. Steroids, Bactrim, you don't usually see fluoroquinolones continued these days, but in the past, I've seen people on very long courses. And over-the-counter allergy or cough medications that have first-generation antihistamines, diphenhydramine, duloxamine, et cetera. These are medications that could actually cause psychosis in some of our patients. And you might not know until you ask the patient to bring in their bottles in a little brown bag. Now, for behavioral and psychological symptoms of dementia, the tongue twister, can you say BPSD quickly 3 times? That is what we are trying to treat with medication. There is no drug currently approved by the FDA. And you've heard me say more than once, non-pharmacological interventions not only should be tried, but need to continue during pharmacological interventions, and absolutely every drug has adverse effects. So systematic reviews and experience have shown that the cholinesterase inhibitors, the donepezil or Aricept, rivastigmine, which is Exelon, galantamine, have significant efficacy in mild dementia behaviors. The biggest one are the people who have memory associated psychoses, such as a man with dementia saying that this is not his wife, or she is not being faithful to him, or something, some sort of a delusion like that. And the cholinesterase inhibitors can wipe that out. It could be a big relief for the patient and the family. I have a patient who really didn't carry a diagnosis of dementia, but she wouldn't eat because her food was being tasted at night by a man named Ron, who came out of the vent in her apartment and went around moving her furniture, taking her underwear, and eating from her refrigerator. Yes, she did have dementia. Then she was willing to take a medication, not to get rid of Ron, because, he was real. You wouldn't eat from something if somebody ate it first, but to help her memory be a little sharper. And amazingly, after she was on donepezil, I asked her what was going on with Ron, and she said, "Who? There's nobody in my apartment." She had actually gained some weight. Selective serotonin reuptake inhibitors. These are referred to as SSRIs. One of the earliest ones was citalopram, which was studied and shown to reduce agitation. It is harder to use this medication at its highest value, its highest dose in older adults because of QT prolongation. I tend to use its cousin, escitalopram. Memantine or Namenda is also a memory medication approved for memory. There are conflicting studies, but it may reduce agitation by 16%. So these are the top three that I reach for because of the least adverse effects of these medications. Antipsychotics is probably the one I reach to last. If I am going to, because of the adverse effects include TIAs, strokes, hyperglycemia, prolonged QT interval, and sudden cardiac death. So it really should not be a first line medication, although I've seen some prescribers use that. I tend to reach for the atypical ones, quetiapine, olanzapine. Those are very similar. Risperidone helps quite a bit with psychosis and aggression. Aripiprazole does belong in the atypical antipsychotic family, but it may actually increase impulsivity because it's a dopamine modulator. Pimavanserin is a fascinating medication. It actually works on serotonin um, receptors. It's an inverse and an agonist, and it is approved for Parkinson's disease psychosis. Um, I have not personally prescribed it for dementia itself. That would be off-label, and there's nothing wrong with trying it. It's very expensive medication. Um, Anticonvulsants have been shown in systematic reviews to have no benefit. If I've gotten through these three and I have some reason to try a low dose of convulsant before going to one of these medications, sometimes we utilize, n- uh, I guess, lesser evidence-based medicine. But these medications have not been shown to be of benefit in studies and should be discontinued immediately if they're not found to be of use. The benzodiazepines for agitation have minimal benefit. They can actually increase impulsivity, and the risks of fall are very high. Buspirone may be a little bit safer for anxiety, for insomnia, which is common in dementia, mirtazapine, melatonin, gabapentin, duloxetine. Sexualized behaviors, naltrexone can be helpful. For people with what we call emotional incontinence due to stroke, that's a pseudobulbar effect. I know that's a funny term, but dextromethorphan with quinidine is approved, very expensive medication. One randomized control study does exist for dementia with agitation. And psychosis, a new player on the block, xanomeline trospium, is actually a remake of an older memory medication that was developed as xanomeline. And xanomeline did not make it through the FDA because as the dose was raised to be therapeutic, people developed diarrhea and urinary incontinence. So it has now been approved for psychosis and schizophrenia when linked with trospium, which is a urinary incontinence medication for overactive bladder. It also causes constipation. So neither I nor my peers at this time have experience using this off-label for our dementia patients, but sometime in the next year, I'm hoping one of you will get back to me. I'm going to jump to driving retirement, and this is a little tongue-in-cheek. My parents used to live in Florida, And I would visit them in their senior community, and we would sit by the pool and I would listen to the chatter. Oh, my vision, it's been so much glare since my cataract surgery. What did you say? My hearing aids are just not working. Oh, my arthritis, oy vey. I'm constantly in pain and I just can't concentrate since they put me on that beta blocker for my heart. But nobody will complain really about cars because they're all driving in Florida. I know some of you guys are going to be in Florida, and you'll acknowledge that that's actually true. So, what is the role of the interdisciplinary team in assessing driver's risk? Um, everybody should try to find out, is the patient with dementia driving, and whose car, and where is he going, and does the person he live with still drive? If the spouse is no longer a driver and you ground the one with dementia, you've grounded the couple, haven't you? You're going to get a lot of resistance from the wife if she is the non-driver, if her husband has to stop driving. Determine if there are non-cognitive reasons for driving cessation. So I have patients who really, once you put them in the car, would really be good drivers. But some of my patients have such bad arthritis in their neck, they can't turn their head. They're just fixed in this position. Some of them have such, are so frail physically, they really can't get in or out of the car safely. Should these people be driving independently? You could say maybe not. If you can't get out of the car or into the car, may not be able to drive it. We talked about number three. You should look at their driver's license and see if it's expired. Sometimes that's the easiest way that somebody can stop driving. Your license is more than 6 months out of date, sir. You know what? You would have to take your driver's test all over again if this is Ohio, and which is true, and ask the patient and the informant about episodes of getting lost, accidents, how did you lose your rear view, your side mirror, and accidents even if the person isn't, quote, at fault. Sometimes a driver is really, really slow, so slow that cars are whipping around them and maybe causing an accident, even if they didn't actually run into the person. And what can the professional in your team do to guide a family member, to guide a family through driving cessation? So, while you're thinking about that, I want to point out that driving as an older adult is challenging because of aging changes in the vision. Low contrast is an issue. We're appreciating things with low contrast. Curbs, urban driveways, dusk, gray cars on cement roads. These slides were created, by the way, by the Henry Ford Visual Rehabilitation and Research Center. Older adults will have a hard time in a cluttered environment finding this rubber band and finding this penny. Which would you rather have drive you or hunt with, if this is central or western Pennsylvania, with someone with myopia? This would be me, without my glasses. Or somebody who actually might test pretty well with their visual acuity, but they have macular degeneration and they may not see that car right in front of them, and they may not realize that this is a car door or a truck door opening or a kid stepping out. They just can't see it. It's a spot missing in their vision. And then there was this poor guy who was 80 years old. This is in Italy. I pulled this from the New York Times. And he decided he needed to get up to go to work at 3 in the morning. He's not working, I assure you, but he got all dressed, got in his car, and he drove to work. Unfortunately, his route took him down, you got it, the Spanish Steps. Luckily, neither he nor the car nor the steps were injured. They did have to take the car off with a crane. He tested negative for alcohol and drugs, and he just said, I was just going to work. I don't know how this happened. Very sad. So, when should a person with dementia stop driving? So, in general, if you were driving safely before dementia, um, you may be able to continue to drive during the early stages of dementia. You have to understand that the changes of the dementia do not happen the few months before a diagnosis of dementia is made. The changes start 10, even 20 years earlier. And during that time, the person may have been adapting to the cognitive changes, may have been taking a little extra time to plan for unfamiliar neighborhoods, may have noticed it was a little difficult to drive without GPS, and may have started it using that. Early in dementia, mild dementia, when there is usually only one instrumental or complex activity of daily living that is affected by dementia. As a doctor, I pick it up when my patients miss appointments when they never used to, or they're suddenly less able to take their medication when they used to be pretty good at it. So those are the instrumental activities of daily living, but their basics are great. They are well coiffed and they don't smell, or they smell good, and they're well dressed, and clearly they're taking care of. They're bathing in their nails and their face, and their basic activity, and they haven't lost weight. Their basic activities of living are intact, but they're slipping in terms of their executive or their memory. So early in dementia, if a person is using GPS or taking extra planning for unfamiliar neighborhoods, maybe self-limiting the time of day or geography, anticipate that in the late afternoon they're fatigued, they may be safe drivers. The studies suggest that in mild dementia, 50% of drivers are safe. It's the challenge to know which 50% you're dealing with. And the closer you get to a diagnosis of moderate dementia, their driving may not be as safe. Moderate dementia is where at least one basic activity of daily living is impaired. It could be their bathing. It could be not using the toilet properly, taking care of themselves, their basic eating, their basic activities of daily living. It's important to stage dementia because in general, moderate dementia is the stage where it is most likely unsafe to drive. Psychosis in any stage. It doesn't usually occur in mild stages, but it might, and it makes driving unsafe, no matter what the stage. So I put this slide here on state and age-specific license renewal. I picked Ohio. That's one of my disclosures. This is where I live. And in-person renewal is required for everybody. And the only change really is as you get older is that after 65, you have to renew your license every 4 years instead of every 8 years. I put Pennsylvania in there for two reasons. First of all, Pennsylvania, I'm not going to go over this in one of my next slides, but Pennsylvania is a state that requires or mandates physicians to report seizures and to report dementia that could affect driving. And some people will come from Pennsylvania to Ohio thinking that I don't know that. So every doctor in Ohio has to report to PennDOT if there's a reportable condition. And interestingly, PennDOT randomly selects drivers over the age of 45 for additional vision and medical screening. It's very interesting. I picked Illinois because it's the only state at this time that requires a on-the-road test once you hit a certain age. It's the only state. I think Puerto Rico does require some in-person testing, but it's 75 currently. But there's been a new bill that was just signed last month, and it is effective in July 2026, and it bumps that age up to 87. I have no idea why they took that 12-year leap. Absolutely none. It's interesting. I couldn't ignore California, which, like Pennsylvania, has a mandatory dementia reporting. And Florida, of course, where all the drivers are and are very proud of their driving. Um, After 80, a vision test has to be performed at every renewal, and that is the only rule in Florida. So mandatory reporting of dementia, the wording is very odd when you get to California, and it's similarly odd in Pennsylvania. So California, the words lapse of consciousness in my mind means a seizure, right? I'm talking to you. Oh, I'm not talking to you. Wouldn't that be a bad idea if you were a driver? But California specifies, and this is the wording, that Alzheimer's disease and related disorders severe enough to impair the ability to operate a motor vehicle is a, quote, lapse of consciousness and requires mandatory reporting by physicians and surgeons. Um, so mandatory reporting in California and Pennsylvania. Ohio, Florida, and Illinois are permissive. I could report if I want to. All states have a pathway for evaluation. So if somebody reports the person, then what happens is that the patient is told that they have to get a form signed by their doctor that says something about whether or not to they can drive. And the doctor might put on there that the person needs to get a driver evaluation. Physicians are mandated for conditions that involve the ability to safely operate a motor vehicle. This is California. And in California, EMTs and peace officers, so policemen, sheriffs, other people who come under the peace officer category, a family friend or neighbor who is no longer a friendly neighbor can report the person. I think there are some laws about how often they can report somebody. Um, Patients are actually supposed to report themselves if they have a new diagnosis. And if they have an adverse driving record, then that could trigger a re-examination. And interesting, California does something that Ohio does not do at all. The only thing that you can add to your driver's license in Ohio is that you have to wear special glasses to drive. But in California, you could drive with limitations. It could specify no freeway. It could specify you can't drive after a certain hour or after dusk. It could specify bioptic telescopic lenses, which are specially lenses to read things that are very small print on the roads. And there are other limitations. So that's unusual. Most states don't have that. Um, Suppose you want your patient to get a formal driving evaluation and not actually test the road test. So I try not, I'm skeptical about these tests. And the reason is that a person could perform great on a test, but maybe use poor judgment and go out in the middle of the night. So I'm careful about referring people. I usually refer them when I think that they really, I'm not sure how well they actually do the mechanics of driving. So you can go to this website, aded.net, and see if there are an occupational therapist or a certified driver rehabilitation specialist near you. A typical time for a visit is 2 to 4 hours. It should include some clinical, like pen and paper tests, and some sort of a behind the wheel. A lot of the places that actually took you out on the road are now putting you in driving simulations instead. And my patients have complained. They said, they didn't grow up, with video games and that sort of thing, and they don't find it easy to do. This is costly. Insurance might not pay. and you could be looking at $1,000 to get tested. The VA has a great driver's assessment program, by the way. So let's just say that a person does get their license suspended. Um, are they going to stop driving? Or, maybe maybe you're gonna tell them that they shouldn't drive and are not gonna push them to actually get their, to turn in their license. You might not report them, at least initially. So I've had patients in rural areas, and maybe you live in one of these areas where law enforcement could be sort of friendly. Patrolman Joe or maybe the police officer will knock, I say, hey, can we have a little cup of tea or coffee, and put his feet up and say, hey, bud, it's really, the traffic out there is really bad and your grandson really needs that car. Let's get you set up where you don't need to drive anymore. I've had patients for whom that works. Don't look so skeptical, but it can work, and it's nice if that happens. Um, Therapeutic fibbing is probably what I turn to the most. I tell the patients to do something to disable the car and then claim it's not repairable and try to get into cahoots with whichever whoever the mechanic is, so that if the patient has the wherewithal to call and say, can I take my car home now? It's working, isn't it? You don't want the car mechanic to say, yeah, it runs great, just come and pick it up Tuesday. They all sort of have to be in cahoots, and sometimes you can do that. You may be able to convince them that indeed the grandson does need the car. You may be able to tell them, when you turn 90, your insurance goes up a lot, or you can, which could be true. And when you turn 90, everybody has to turn in their driver's license. So, I mean, that's definitely a fib. There are tens of people, 100 years and over in Ohio, who have valid driver's licenses. So I know that's a fib. But fib and allow your families the opportunity to let the patient save face. The last thing that the patient wants to hear is that you are not a safe driver, because that one is going to turn around to you and say, honey, I've been driving longer than you've been alive. I've been driving since I was 12. I drove on the farm. And, you're just going to get this. You can't go through it. Blame it on anyone but the patient. Try to figure out a way. If you've tried everything, you may need to remove the car legally. You really just can't take dad's car if dad is going to report you to the police. You just can't take it. So if you can, great, you've talked him into it. But let's just say that dad has the wherewithal to report you to the police. You may have to become dad's guardian and then remove the car legally. And in Ohio, that's not a one-step process. You can become the guardian, but the court has to approve you're taking away the car in order to prevent some of the guardians taking advantage of patients and or their wards in some cases. So now it's your 2-minute check-in. You've had drivers who you're pretty sure have been unsafe. What have you done in the past? What's worked for you? Have you checked your ADED.net to see if there are assessment and rehabilitation specialists in your community, and how much do they charge? And do they do it on the road, or do they do it with sort of the digital thing? And what will you take from this session to add to your toolbox in assessing patients for driving retirement? Take 2. Oh, the best is yet to come, the last part of this talk. Firearms and frail hands. There are some parallels with driving. There are some differences. So we're going to be talking about the role of the interdisciplinary team in reducing firearm injury. And you have to start with somebody in your team. has to ask if there is a firearm in the home. In the VA, when I practiced at the VA, a veteran didn't usually just have one firearm. There could be 4, 5, 6, or 7 firearms in the home. Does your patient have any mood disorders or dementia behaviors, especially psychosis, making firearms risky to the patient and making firearms risky to the community? Does your state have a red flag or ERPO law? Do you know what that is? And what mechanism activates it? How can members of your interdisciplinary team help guide a family through firearm safety? So one of the geriatric fellows did a study in our memory clinic. The first 495 patients who came through one year were queried, who came through with a complaint or a concern about cognitive impairment. They were queried about possession of a firearm at home. And among the, and 18% of those patients, 89 out of 495, had a firearm at home. Among the patients who were actually diagnosed with dementia, about the same, 17% had a firearm at home. Among those, almost half had delusions. A fifth endorsed hallucinations. And most of the delusions and hallucinations were of a paranoid or hostile quality. And in rural areas, you're seeing firearms in the home for hunting. In urban areas, you're seeing them to defend yourself. And there's crossover, of course. So if you feel that your patient with dementia should not access firearms, what do you advise? And how do you know? So it's very similar to driving in that in the moderate stage where you're having trouble putting, a patient is having trouble with a basic activity of daily living, that's pretty much the cutoff where firearms should not be in frail hands. Mild dementia might work, but anyone with any degree of psychosis should not have access to a firearm. So removal, if you're able to, sometimes this is a fight within the family. Restriction of access might work. So is there a gun locker in your home? Is it locked? Is the key not available to the patient? And is the ammunition separate than the gun, just in case the patient were to get into the gun locker? There are gun locks. This is one of the gun locks that I used to keep in the exam room of my office at the VA. And patients don't like these because, you know, they want to be able to look at their gun. They might want to check on it. They know when they see this that they cannot access the gun, and it makes them unhappy. It is possible to do what museums do when they display guns. They're not displaying a gun that works. They're displaying a gun that has been temporarily disabled, not permanently. If you have a firing pin, it can be filed down or it could be removed. If somebody were to get that gun, they could make it active again. But in general, your patient with dementia will not know that this gun is disabled. So this isn't something that you do on your own. You take this to a gunsmith and have the gunsmith file the firing pin or remove it. Other interventions to reduce firearm injury. Can a family member remove a gun from the home? It is, there are rules and there are codes, and we'll go over that. There are both federal and state. It's subject to legal action. If you take away dad's firearm, dad could notify the police. the value of the firearm. Some of these are passed down from generation to generation. What's the safety of the household if your son takes dad's gun? And does your son have children in the home? And then transferring firearms without a background check might not be legal in every state. So the first code is the federal one based on the Brady Bill. So it is not lawful to sell or otherwise dispose of, like give, a firearm to any person knowing or having reasonable cause to believe that such person, here's a long list, mm, has been educated as a mental defective or been committed to any mental institution. Horrible wording to attribute to someone with dementia, a mental defective. It's horrible. But in Ohio, this is sometimes the only way that I can have a gun um, removed from the person's home, because once they are a ward, um, Ohio, if you are a ward and you have been declared or educated as a quote mental defective, which is an awful term, in Ohio you cannot possess a firearm. So the firearm can be removed by state codes, the Ohio Revised Code, and then because of the federal code, the person can't buy it. Nobody can sell it to this person as long as there's a background check. And background checks are required at every gun dealer. So, and the background check will, once the guardianship comes through, checks the guardian list. So that person will not be able to sell to my patient who is now the award. It's harsh. And again, you can test a person for driving. We don't have a way to test them in firearms. I can get a person's license to drive suspended without making them into a ward. And I can't do that in my state, and probably not in yours. Just if it's involving a firearm. So some cautions about things that you might advise a patient. So bringing a firearm to the police station and asking them to dispose of it. Keep in mind they are going to ID that firearm. And if that firearm has been involved in a crime, now you're going to have to figure out when was the crime, who owned it, who touched that firearm, who had access to it. You could really stir up some things that shouldn't be stirred up, that you may have no control over. There are periodic buybacks without liability by law enforcement, no matter how many of the crimes that firearm was used in, that firearm is hopefully destroyed. I know people who know this stuff well will hear about times that hasn't worked out. If this is a historic firearm passed from generation to generation, and it may be quite valuable, it's going to be destroyed, period. You can't go and get it back the next day. Private sales. In Ohio, there is a loophole for background checks. So you could go to a gun show and sell it to a person, and that person won't undergo a background check. Now, if you are selling professionally to make a profit, there is a federal rule that is implemented to varying degrees in different states, but where they have to check the background. But I don't know, in all honesty, how well it's checked. And it's a new rule. It is preferable for you, if you want to get rid of the firearm, to take it to a licensed dealer to sell on consignment. The buyer will undergo a background check. A licensed appraiser can come to your home so you could find out, was this a firearm that was bought on Walmart before they stopped selling rifles? Or in which case it may not be worth much, or is this something dating back to the Civil War where it could go for quite a lot of money? Red flag laws depend on the state. I have lived in Texas and practiced in Texas, and I've lived in Ohio, and red flag laws are not here. and you can pursue guardianship, which is something sadly that I've had to turn to. But in some of you actually live in states with ERPO laws, extreme risk protection orders, or red flag laws. The laws allow families, household members, or police to petition the court to temporarily restrict access to guns. This was done to try to prevent mass murders because in some, although certainly not in all of them, the person who is allegedly the mass murderer sort of collected those guns at the last moment, or the ammo at the last moment. It hasn't really worked out. However, for every 10 to 20 guns seized in Connecticut, one suicide has been prevented. And since passage in Indiana, fewer suicides. So there appears to be a link between harm to the person's self, and that's very important. These are the laws, Ohio, Texas. I actually did work in Delaware, but the rule was not in effect at the time I was in Delaware. So, 2-minute check-in. What firearm retirement interventions have worked for you, and what will you take away from this session to add to your toolbox in assessing patients for firearm retirement? So here are the key takeaways. Actionable strategies and resources for each of you on your team. De-prescription for dementia behavior really may be underutilized, and I would urge everyone to see if you can, before we start adding medications, if there are medications, if you can find somebody that you work with who could look at the medication list and see if any of these could be worsening the behavior. The biggest ones, and I touched on this very, very briefly, are medications with dopaminergic activity. So the Abilify, for example, might have been just started for behavior problems, but escalated because it has some dopaminergic activity. There are patients who were put on medications for restless leg syndrome and were put, when the guidelines actually said to start ropinirole or Mirapex, actually were sort of took restless leg behavior up to the next level. And the patient displayed a lot of restlessness. And stopping the ropinirole might be helpful, and using a different medication. Ropinirole and Mirapex are used in Parkinson's disease, as is levocarbidopa or Sinemet. And dementia behavior problems at night may be reduced if the Parkinson's disease medications were reduced at night. So de-prescribing needs to be collaborative with the person who originally prescribed it, if possible, and try not to get on your neurologist's bad side. But many of them may not realize the problems that their medications can cause. Persons in a moderate stage of dementia are most likely unsafe with both cars and firearms. Special attention needed for mild dementia. Persons with dementia psychosis are likely unsafe with cars and firearms at any stage. Restricting access is the best initial approach for cars and for firearms for safety. Pathways exist to testing driving, but not firearms by state. In general, you just can't take it away. There are legal consequences. With firearms, gun locks and lockers are low cost, low effort, high return when the key is inaccessible. We talked about what museums do, filing the firing pin or having it removed, and consider selling a valuable firearm on consignment. And then guardianship prevents firearm purchase by a person with dementia in all states, and ownership as well in some states. If the need is urgent, invoke ERPO and/or involve law enforcement. If the above efforts are unsuccessful or cannot wait, the 6 weeks that guardianship takes, which is what it takes in Ohio. So I want to thank everybody for sticking it out through this long talk. This is a potpourri of topics, and you could create a talk or go to a talk on any of those, but I put them all together because these are the real pressure points in dementia behavior. I hope I've been able to stimulate meaningful discussion among your interprofessional group during this session, and I hope you are all stimulated to jump into the fray of caring for the most difficult issues in home care and in the older adults that we love. And I hope that you feel more confident about managing these pressure points.
Excellent. Thank you so much, Dr. Barbara. We're so grateful for you sharing your knowledge, your experiences, your recommendations. As you said, what you covered today, they're important topics, and you've provided the audience with some really valuable learning. So we appreciate you. And with that, we've come to the end of the webinar. Follow the credit claiming instructions that your facilitator will provide to you. And once again, thank you so much for joining us. Have a wonderful day.